Good morning, everyone. I'm going to call to order the Joint Senate and Assembly Committee of Subcommittee on Human Services. Madam Secretary, will you please call the roll?
Assemblywoman Anderson. Present. Assemblywoman Dickman. Here. Assemblyman Hafen.
Here.
Assemblywoman Hadagi.
Here.
Assemblywoman Moreau-Moreno.
Here.
Assemblyman Watts.
Here.
Assemblyman Yeager.
Here.
Senator Cannizzaro. Senator Dondero Loop.
Here.
Senator Severs-Gansert.
Here.
Senator Titus.
Here.
Assemblywoman Gorlow.
Here.
Chair Nguyen.
Here, and anyone that is missing, if we can mark them present when they arrive. And I know that several of our members of committee today have some bill presentations, so it's already that time of year where people might be slipping out. So we have a monster of a calendar here today, so we will go ahead and get started. Just as a reminder to everyone to please silence their cell phones and electronic devices. I had to do it myself because mine was going to go off as well. And today, as a reminder, public comment will be available at the end of the meeting after these budget presentations. And with that, I will open the budget hearings and ask the divisions to come up to the table and begin when ready. And also a reminder to please state your name before you speak.
Good morning, Madam Chair and members of the committee. My name is Richard Whitley, and I serve as the Director for the Department of Health and Human Services. And I have two budget accounts today to present, and they represent pass-through funds to the Division of Healthcare Finance and Policy, or Nevada Medicaid. Both accounts serve to make supplemental payments to hospitals. On page 3 of my presentation, budget account 3244 is the indigent hospital care. This budget account was established to reimburse hospitals for care provided to persons who are indigent or don't have a health payer source. On page 4, this budget account receives two primary funding sources, the ad valorem tax and the unmet free care obligation. As laid out in NRS 428.115, the Board of Trustees determines the priorities for the account. There are no major changes in this budget account, and so I'm happy to answer any questions.
Do we have any questions on that budget account? Seeing none, we can go ahead and move on.
Great. Again, Madam Chair, for the record, Richard Whitley. Budget account 3260 is the upper payment limit holding account. This is another pass-through account associated with the private hospital upper payment limit. Slide 7 shows the total projected amount of the contracts and the amount projected to be reverted to general fund or the Fund for Healthy Nevada. And there are no major changes to this budget account, and I'm happy to answer any questions.
One second, Director. I think I have a question from Chair Gorlow.
Thank you, Chair. Good morning. I do have a quick question. On the contracted services that are anticipated to be provided by the nonprofit organization, how are they identified?
For the record, Richard Whitley. We work with the nonprofit Nevada Clinical Services to determine the appropriate opportunities to partner with them and have to actually leave no stone unturned in terms of what opportunities exist with that nonprofit. So anytime a new funding stream comes in or funding has been identified, we do review it to see if it would be and work closely with the nonprofit.
I think I have a follow-up question here with Senator Titus.
That's all right. Thank you, Madam Chair. It happens to both of us, I think, a lot this session. So I have a follow-up question regarding the nonprofits. I'm just wondering about the accountability and how does the state then monitor that when you have now turned this over to them, that it's actually the results of what we wanted, or where's the accountability piece?
For the record, Richard Whitley, we utilize the same scope of practice, scope that we would if we implemented the services directly. So it is a very congruent process with what those scope of activities are. And then we do monitor them for outcomes. And so happy to happy to provide more detail on that if requested. But we do treat it as if we are providing the services. I mean, that's part of the negotiation with the nonprofit.
Do we have any other further questions from the committee? It doesn't look like it. You can go ahead and move on to the next budget.
Good morning, Madam Chair. Stacy Weeks, Division of Healthcare and Financing and Policy. I have here with me today Lynette Aaron, our Budget Officer, who is our ASO4. I also have several members of our team with us this morning to talk about our budget. All right, if it's okay, Madam Chair, I'm going to kind of skim through a couple of slides and skip to the meat of the presentation. I think some of you have seen these a number of times.
That would be greatly appreciated.
Okay, great.
Thank you.
It is a lengthy presentation. I apologize, but it is a big budget. But I did want to note before we move forward that we have a few updates to our organizational chart for our leadership team. We, the last time I sat in front of the pre-session hearing in front of the committee, we mentioned that our deputy administrator for fiscal budget and payments was open position. We have now hired Amber Law, who comes from the treasurer's office, who has years of experience in state budget as well as in our department. So we're super excited to have her. It's week 2, or she'd be sitting here next to me. She's still learning, but I'm sure you'll be seeing more of her this session and future sessions.
I think she's in the back row. Is that
yes,
correct?
she
Oh,
is.
there
Yeah.
she is, everyone.
We're all in blue, I think, today. So also, I would just note that Teresa Carson, who is an acting deputy over managed care, is now officially taking the position as a deputy administrator. So I'm super excited. She was worked in our managed care program for many years, and she also has experience in behavioral health. And so to better spread the workload across deputies, we did restructure and move behavioral health under her as we work to integrate behavioral health into our system. All right, so let's move forward. And also, I just wanted to correct something that was shared last time. I did say 1 in 4 Nevadans are covered. It's actually 1 in 3 based on the latest census data. So I just want to make sure members are aware of that. All right, and then I did want to note on this slide here, this has to do with the PHE unwind. I won't go into as much detail as we went into last time, but I think I just wanted to note the last bullet there for the budget impact. Because we are losing about the 6.2% enhanced FMAP over the next year, or this calendar year, as you can see, it steps down by quarter. We'll be looking at $120 million impact to the general fund with those losses. And this slide here walks through some updates we have from our analytics team, Office of Analytics, based on some questions that members had last time about where these people live. We tried to do some high-level analysis and estimates. This is just about a sample of the population. I mean, we're able to look at 50% of the population because of SNAP redeterminations. And as you can see here, there are some concentrations across the state. But again, this is just 50% of the population. But we did look at utilization of services, and as you can can see there are some utilization of services. At least 77% had at least one healthcare service from a core service provider in the past year. And as you can see there, 50% for physician services, 45% for primary care providers, and 9% for behavioral health providers. And there's some utilization numbers there as well. And I'll skip through that one since you guys have seen these before. And just a note that this has not changed much either since we met. As you can see, during the pandemic, our enrollment went up a lot. It went from around 600 or lower to about 900,000 today. And as you can see, it will start to drop off as we work through the PHE unwind, which, as I mentioned last time, we begin some of that process in April. You'll start to see some of the first redeterminations, and people may be falling off coverage in June, and it's going to be like a 3-month cycle from there. So every 3 months, you'll see a wave of people that will be falling off. But we're doing the 12-month cycle so that we don't overburden our system and overwhelm our capacity. And checkup, as you can see, it's ramping up, slowly over time to about 25,000 in 2025. And this slide you've seen before too. This is all of we have 7 accounts. We're going to talk about each of those today. I would just note 3177 is our new account for the hospital provider tax that's established under state law. So what we're asking for this year is to establish that account. So if we are able to get the authority to begin that provider tax and those new payments, we'll have an account to do just that. And if I'm moving too quickly, please someone stop me. I just want to be mindful of time and so people have questions. So the first account I want to talk about is 3157, and that is our intergovernmental transfer, IGT account. So I'll throw out some acronyms today, but IGT is what we often refer to for this account. IGTs are really the non-federal share of Medicaid. So typically the state, we have to do a state share and federal share to pay for services. Federal law allows us to take locality funding, counties, school districts, for example, public entities to pay the state share. And that's what this count does. It collects those payments from our counties, school districts, and other public entities that voluntarily offer funding to pay the state share to enhance payments to providers in their communities. So that visual there is trying to, capture that simply. That's what kind of makes up our non-federal share for a portion of several payments. So the first one there is our Medicaid supplemental payments to hospitals. And again, we do cover hospital services. This is just allowing us to increase on top of that base rate. So it allows for that supplemental payment. And we often refer to this as our UPL program. It's an upper payment limit. And this isn't our fee-for-service program. Federal law does not allow us to pay higher than Medicare. So that's what the upper payment limit is. So it allows us to increase our base rate up to Medicare. And so that is that program. We also have a disproportionate share hospital program. We often refer to that as DISH. This is a really important program for our safety net. A lot of hospitals that have uncompensated care benefit from this program. And we'll talk about today some changes to that program, and you'll see those in the budget slides here soon. Graduate medical education, I would just note that we currently have 3 participants in that program in Medicaid: the University of Reno in Nevada, Humboldt General Hospital, and University Medical Center, and that's about $30 million annually for that program. We also collect IGT funds for school-based healthcare services. That's, again, increasing and enhancing what we currently pay for those services for those localities that are willing to pitch in the IGT. And then also emergency paramedics. All right, so budget account 3157 has 2 key enhancements I wanted to note today. The first one, E351, reflects changes to the state's FMAP claiming on supplemental payment programs and GME, where Clark County's portion of this federal share goes from 60 to 87%. This results in a net reduction of about $3.6 million in the next biennium to this budget account for the state. The second, and we'll talk again later, you'll see in 3243, the companion budget unit item that reflects some of the changes in the budget. So we'll get to that in a minute. And the second item here reflects the funding change in this account that relates to the state's DISH program and Clark County's contribution to the IGT program. And again, I will go over that in more detail toward the end when we get to the medical services budget account. So I just wanted to note that here. All right. So the second account we have is 3158. This is our Medicaid administration.
Actually, if I can just stop you really quickly,
Yes.
I know we have a couple of questions here on
okay.
this particular
Oh,
budget.
sorry.
and
Well, stop by.
No,
Yeah.
that's fine. That's fine.
Yep.
And if they come up, I'll just stop you if that's
I'll stop.
okay.
Thank you. Yeah.
I think we have a question from Assemblyman Hafen.
Thank you, Madam Chair, and thank you all for presenting today. Looking at the FMAP cuts, it looks like about 120 plus million cut. You guys do have a proposal to the provider fee that looks like it would pick up most of that and then some. But I'm curious about the uncompensated care that's currently being provided by UMC, and how that decrease compares to the recommended decrease and disproportionate share of the hospital payments.
Madam Chair, through you to Assemblyman, that is a very good question. So first, I just want to note the 6.2% in the provider fee. The provider fee does not offset the 6.2% loss to the state programs. I just want to note that those payments go to the hospitals. But the piece about the DISH program, so there is a reduction to UMC. A lot of that has to do with and we were going to mention this later, but I'm happy to walk through it now. The DISH program, because we have expanded Medicaid in Nevada, a lot of the uncompensated care levels for UMC have gone down. And so they actually hit their limit on DISH, and they end up paying back about $30 million annually. So that's a pretty big financial problem from them each year in planning their budgets. And so the request was to reduce for just UMC, hold the other hospitals harmless that are benefiting, and that's what this new structure does, and offsetting some of those losses to UMC through our state-directed payment programs on the managed care side. So Clark is offering new IGT to help offset those losses through our managed care program, which doesn't have a limit per se, like as much as the DISH program. Is that helpful?
Very helpful, thank you. And I just want to say thank you guys because though we're losing, looks like about 120 million in FMAP, it looks like we've actually, as a state, done a great job enrolling individuals in Medicaid. And so that's, I just want to congratulate you guys on that. That's good news. Thank you.
Thank you.
I think we have a follow-up question or another question from Senator Titus.
Thank you, Madam Chair. Yes, well, I have actually two questions. One is a direct follow-up to that one because I'm not sure we're actually losing $120 million because it's my understanding on the FMAP, that 6.2%, that was almost a gift. It was more than what we had projected, and it went longer than what the federal government told us that they were going to, how long they were going to give it to us. And so that in past hearings, we hadn't been spending that money. There was this reserve because we didn't know how long it was going to last. And it went way longer than we thought. So now, yes, it's $120 million less because of stopping, but was that really ever allocated? Is that really a hole, or was that a surplus?
Madam Chair, through you to Senator Titus, I'm going to defer to Lynette Aaron, who understands the budget mechanics for the general fund much better than I do.
Thank you for the question. In response to that, the reason that is
I can have you
correct.
state your name for the record.
Oh, I'm sorry.
No, that's okay.
For the record, Lynette Aaron. The 120 million impact to the general fund, that is just showing the change from what was legislatively approved with the FMAP. For fiscal year 22, the FMAP was 65.87%, and with the new changes to the FMAP as a result of the unwinding and the PHE ending, the FMAP for fiscal year 25 is now will be 61.57%, which is an overall decrease of 4.3%, which reflects that 120 million impact in general fund.
So, so again, if I might clarify that, so it's not actually a hole per se.
That is correct.
Okay, thank you for the clarification. And then a separate question?
Yes, but I will remind you, Senator, we have quite a few
All right,
budgets
this
here.
is a quick one. So on the graduate medical education component, there's 3 hospitals that funding can go. We had a residency close in Elko, lack of funding. And so is there no avenue through this kind of program that we could support other residency programs?
Madam Chair, through you to Senator Titus, Stacy Weeks for the record. That is something I can follow up with after, but I think, yes, we could look at adding more programs.
Any other questions from committee members? Go ahead, Senator Severs-Gansert.
Thank you, Madam Chair. Just to follow up on that, Dr. Titus specifically talked about ELCO, but I know we've had some of us have had both medical schools approach us about expanding GME. So when you get back to us, would you mind looking at opportunities to be able to use federal dollars? Because normally I think you're able to establish a program and then Medicare will come in and reimburse residency programs, but it was portrayed or suggested that they won't do that. So if you could follow up, that would be great. Thanks.
Madam Chair, through you to Senator
And feel
Gansert.
free to go directly
Okay,
to
thank
the
you.
question and answer.
Thank you. It's early. Senator, yes, I can follow up on that and send you guys the details about what would be required for more providers to participate.
Thank you. You can go ahead and move on
Okay.
to 3158.
Great, thank you. All right, so this budget account, 3158, is our Medicaid administration budget account. It collects funding for the mandated administrative activities that we carry out at the division for Medicaid, and also related costs and activities for vendors and other resources that we need to operate. I did want to note today some of the federal matching funds that we get for our administration budget, and that for general operations, the federal government for Medicaid, if the work is related to Medicaid program, we can match 50% financial federal participation. So they will cover half of those costs. For our MMIS system, which is one of our systems that relates to provider enrollment and other issues or billing, 75% can be matched FFP. And then eligibility and enrollment changes and updates and information technology systems, we can draw down 90% federal matching funds. All right, so the next, next several slides, 3 slides, are positions that we think we need at the division to not only continue and sustain the current operations, but to take on some of the new things that are being added in the budget or that were added previously in previous years. The first one here is a big one. It's our hospital provider tax. I know we talked a lot about it last time, and we can talk more today as well. But this item just reflects the positions that we think we need for the startup, right? So just trying to get through the next year and making sure we have the capacity to implement the program. Being frank with members, currently it's almost all of us hands on deck to do this work, and it hasn't even started. So having additional staff to take on that and become experts and be able to take some of that weight off of some of the current staff that are trying to catch up on items is a really important piece. We do expect, though, that we're going to need additional staff that are not reflected here, but we expect that the administrative the ability for us to take some of the revenue from the provider tax for administrative costs to use some of that funding to hire additional staff. The second item and the last item here are needed for compliance reasons for our third-party liability program, so we can collect what is owed to the state. And as well as our fair hearings program. There's one specialist that social services program specialist 2 that we need for that program. The next 3 items, again, are related. A lot of them are related. The last 2 especially are really related to some of the current functions needed as well, or the last one is related to the current functions we need in our fiscal and budget program. As you can see, there are a number of positions here that we need to better support our budget team. I think we'll talk a little bit in a minute, but once we get the positions, it's also hard to hire for them as well, and then also training. So, when we hire, sometimes it takes 6 months to 9 months to really get someone up to speed on Medicaid, as it's very complicated. So these positions are very important, but as we can hire, we have to ramp up to be able to really fill that new capacity. I would just note E227 is our statewide managed care program. Ask for 2 positions to support that effort. Going statewide will require us to have more things in our contracts and to have bigger networks that we're going to be having to review and just to better support that program, generally speaking, because the larger it gets, the more money that's involved, the more people we need to have contract oversight. The first one there too, the self-directed program. So this one here relates to continuing some of the new ARPA-related HCBS Home and Community-Based Service Waiver Program initiatives that we've funded with ARPA, and this is continuing some of the staffing related to that. And then these here too, so the last three, I think we have one more slide on this. All payers claims database. This reflects some of the costs that we need to add position and also some implementation costs for the APCD program. This was passed last session, but some of the funding, we expected federal funding to actually help lift this off the ground, but that federal funding did not come through. And so we are asking for the state funding to implement the APCD program. The next item here is Enhancement 357, which is our Tennessee Support Services work. We are currently implementing housing supports and services in both managed care. I mentioned earlier we're doing the managed care piece at no cost to the state as an optional service in managed care, and this item here would be helping us bring in positions to help us stand up the state plan side and looking at what benefits we can use to add that to our fee-for-service program and for recipients. And the last item here is our Enhancement 370. This funds 2 positions needed as we expand our Certified Community Behavioral Health Centers program from 9 to 15 providers. We do need additional staff to help support that program. Just a reminder, this program has a lot of federal quality metrics and state quality metrics that we monitor, and so some of the work around that, we just need the support to do that and make sure we can support providers as they try to become a CCBHC and sustain that status, because it does allow them to bill a more beneficial rate. And then this slide here reflects the vendors and resources we need for the program. These are all related to compliance activities, especially the last 2 are ongoing items that we are required by CMS to do. The first one, though, here is new activities that CMS is asking us for. And so we're asking staff to support that in addition to the last one there, the managed care. We have to monitor quality in our program, and we have to hire an external independent review entity to do that work. We're currently going back out to bid, and so this is funding, though, to help support some of that program with that vendor. And the last 2 items here reflect, again, more vendor resources that we need. And I would just note, as it is harder for us to hire staff, these contractors become more and more important to our work. I know sometimes it's not always fun to add more vendors and more contracts, but we really do rely on our vendors. And so these resources, I know, as you see, they can be maybe a little higher than staff, but, often we are relying on them, especially now. This first item here will help us increase onboarding of new providers to our state certified health information exchange. And the last one here will increase funding for our current actuarial contract to allow us to do prospective risk adjustment. And this has to do with our rate setting process. I mentioned last time we do that on an annual basis. Each year we set the rates for the managed care plans. This allows us to do that in a better way, especially right now as there are a lot of unknowns with our population and enrollment and the unwind, and this will allow us to adjust rates and adjust in a way that doesn't, that keeps holds the state a little more harmless in that process, as well as the managed care plans. So depending on if we see increase in cost or lower costs, we can adjust and try to mitigate any financial losses. And this slide here summarizes our positions in the base budget and enhancements. I just wanted to note, I know last time we met, I think we had a little bit of a higher vacancy rate. We were able to hire new positions, but there are people, it's kind of once we hire 2, we lose 1, right? So it's a little bit of it's a win and then it's not. But we are working hard to fill positions now. I just wanted to note where a lot of our vacancies lie, especially as we look to adding new programs and that are important to our beneficiaries, that we do need to take into account our capacity at the division, not just to do the new stuff, but also our current work. 28% of these vacancies right now are in our division's fiscal budget and supplemental payment team. which is working really hard at this very moment to keep up and to also catch up from COVID. Also, we have 21% vacancies in our district offices, and these are our care coordinators that work with recipients who cannot get to find a provider or need some care coordination. So these are really important positions for our recipients. And then 15% is in information technology, and the rest are scattered throughout our division. All right, I'll stop there, Madam Chair, and see if there are any questions on positions and admin.
We have quite a few questions.
Okay.
I know we're going to have lots of questions from committee members, and just if you can give us some patience too. I know the internet has ceased to exist in this room, and I'm sure other people have realized that as well. So if you have a question, please flag me down here. But I think we can go to Senator Dondero Loop first.
Okay, because I got the blue memo. Thank you.
Yay.
So if the public option funding and personnel are eliminated as recommended by the governor, does the agency anticipate it'll be able to submit the waiver by statutory deadline of January 1st, 2024?
Madam Chair, oh yeah, sorry.
That's okay. Feel free to go directly to the senator.
Senator Stacey Weeks, for the record. Yes, right now that application has already been drafted and is online and available. So in implementing state law, we would need to submit that by January 1, 2024, which was in the original legislation.
Okay, thank you so much.
While we're on the topic of the public option, does anyone have any other further questions regarding that? No. Seeing none, I think Assemblywoman Monroe Moreno has some questions.
Thank you, Madam Chair. I have a few. And they're on the statewide management care E227.
Your microphone, please.
My mic is on. Can you
Oh,
not hear me?
no. It is.
I have a big mouth.
There you go. There you go. I knew that. I knew that.
Sorry. I'll come closer to the mic. How's that? Is that better? Okay. You don't want me to yell at you? No? Okay. Just a few questions. Could you tell us what are the primary challenges, and you may have covered this in the presentation, but what are the primary challenges related to the recommended statewide expansion of the managed care organization delivery model?
Stacey Weeks, for the record, Division of Healthcare Financing and Policy. Assemblywoman, that's a good question. I think we will learn as we go. I think some of the challenges always are, we're going to have to do a new contract, ensure that there's network adequacy in our rural areas, also making sure that the rates paid through the managed care program are sufficient to sustain those networks and ensure access if we are moving statewide. I think those are always challenges that any state faces when we go statewide, especially in rural areas. I would note that Senate Bill 420 last session included directed payments to a lot of our rural. If we move statewide, it requires us to do state directed payments through a managed care program. And what essentially that says is that we will be telling the managed care plans that they have to pay what the providers receive today at our fee schedule or better. So that is, I think, a benefit. Otherwise, I'd be sitting here saying I'm worried about that. So that does help, I think, ensure that there will be no losses to those safety net providers with the expansion.
Perfect, thank you. And that leads me to my next question. What's prevented us in the past from expanding the delivery model?
Assemblywoman Stacey Weeks, for the record, I'm not sure. I'm new to Nevada fairly, but my expectation is that it is often hard for managed care organizations to build networks where there are not providers. I think the expansion of telehealth has made this statewide expansion possibly a more viable option for the state. It also helps save the state money because our managed care program overall does do better in sort of managing care. Fee-for-service is not managed care.
And that led right into my last question. I think it's my last question. So how would the statewide managed care organization program impact the individuals receiving the services through the waiver and the county match budget categories?
Assemblywoman Stacy Weeks, Division of Healthcare Financing and Policy. So the populations that would be involved or part of the populations that would be excluded from the statewide expansion would be our waiver populations, age and blind and disabled population, as well as our the children in the intensive behavioral health services that are currently fee for service. So I think that's when you're talking about your county matched population. So this would be our families and children. And parents and individuals without children, and some seniors would be part of the expansion.
Thank you so much. And I'm glad I didn't have to yell.
Me too.
Assemblyman Watts.
Thank you, Madam Chair. I'd like to kind of follow up on some of the questions that my colleague was just asking and take it to a little bit of a bigger picture level. So for the current fee-for-service participants that would be transitioned to managed care, how would the quality and availability of Medicaid services be impacted, and how will we kind of keep track of that?
Assemblyman Stacy Weeks, for the record, Division of Healthcare Financing and Policy. So unlike fee-for-service, where we don't track any quality or any, we do have access requirements now, but I will say CMS has not enforced much along those lines in a long time around states. Unlike the fee-for-service program, managed care requires us to track quality and to ensure services and network access are being met. We have a lot more tools in the managed care structure. I'm not going to say managed care is perfect, though, so I don't want to overpromise, but I do want to say it gives us more tools to do that.
And I believe I have a question from Senator Don Darrowloop.
Thank you very much, Madam Chair. Can you detail the increased number of requests for fair hearings that are being experienced by the agency?
Senator, I'm gonna defer to my colleague, Deputy Sandy Rubelid, who's in the audience, to come up if she can answer that question.
Thank you.
Good morning, Sandy Rubelid for the record. We don't have that exact figure. We can certainly bring that back. I think the goal of having this position located in Las Vegas is to reduce travel. We have staff in Carson City that have to travel down to Las Vegas for the hearings, which is the majority of where they are held.
Understand. Thank you very much. Look
you.
forward to hearing that information.
Thanks.
I think we have a question from Assemblywoman Dickman.
Thank you, Madam Chair. I just had a question about under American Rescue Plan Act funded programs. It looks like in Decision Unit 248, you want to continue 7 positions. So if you intend to request continuation of the fiscal and program support personnel beyond the 2023-25 biennium, what funding sources would replace American Rescue Plan Act funds to continue those?
Assemblywoman, are you talking, sorry, Stacy Weeks for the record, Division of Healthcare Financing and Policy. Are you referring to E248, the fiscal and programmatic support?
Yes.
So that is not ARPA funded. Those are new positions that we need to do our current programs. Sorry, I apologize for confusion. The first item there is the ARPA funded positions that we want to continue and to support that program. But I see that you're saying, are you asking if we're continuing that funding ongoing?
Yes.
Yes. That's my understanding, Lynette. I'm going to defer to Lynette Aaron to make sure I'm not misstating anything.
That's okay. For the record, Lynette Aaron. So for E248, those positions are actually being requested with ARPA funding, and for us to continue those positions in the upcoming in the next biennium, we will need to request additional funding with general fund and then match it with federal funding.
Okay, thank you.
My apologies.
Thank you, Chair.
Senator Severs-Ganser.
Thank you, Madam Chair. I want to go to the tenancy support program. And so there's a request for a couple of personnel on that program. But looking back to last biennium, it doesn't look like any funds were spent. The program was not up and running, as far as I can tell, last biennium. And so how do you anticipate lifting that program up, and how many dollars are associated in the general fund?
Senator Stacy Weeks for the record, Division of Healthcare Financing and Policy. You are correct. We had challenges with the authority that is under state law that we were supposed to seek, which is a 1915I state plan change. We had some issues using that authority. So now we're looking at using a different federal authority that we think will be easier for counties and providers to be part of on our fee-for-service program. We anticipate being able to cover the cost in our current budget for that program, because we're also picking up a lot of these services for a big portion of the population that we have found that are homeless and through the managed care program.
So with that, I mean, how many folks do you think you're going to be able to help who are homeless, or what do you think the outcomes are going to be for people who need those services?
Senator Stacy Weeks for the record, I'll have to follow up with you on those exact numbers. We do have them in a breakdown by managed care and fee-for-service. Sorry, I don't have them with me today.
That's helpful. Thank you.
And if you could provide those answers that you get to the full committee, that would be wonderful. I think we have a couple of questions from Assemblywoman Howdigy.
Thank you, Madam Chair. Can you hear me? Okay. And I have questions regarding the All Payer Claims Database, Decision Unit E353. And so just two questions on my end. One, I was wondering if you could walk us through what the timeline and implementation is for the database, and then I have a follow-up to that as well. Thank you.
Madam Chair, Assemblywoman, I'm going to call back up Deputy Sandy Rubalid, who can talk about that because she's implementing that for us.
Good morning, Sandy Rubalid for the record. So we just released the RFP for our APCD, so we do have to get a vendor on board. I believe the timeline is January of 2024 for the implementation, but I'd have to I could get the detailed project plan to you if that would be helpful.
I think January 2024 is sufficient, so that's when you're expected to be online and running.
Yes.
Okay, perfect, thank you. And then just a follow-up question, can you provide us information on how much the ongoing maintenance and operations of this database is going to cost?
We could get estimates based on other states until we have a contract in place. Sorry, Sandy Rubalid for the record. Until we have a contract in place, we don't know the exact figures. We would have to look at other states.
Okay, thank you. I mean, is that something you guys are planning to do, to get an idea?
Yeah.
Then once you get that cost, if you would just share it with us, that would be helpful. Thank you so much, and thank you, Chair.
Sure. Thank you.
No problem. Do we have any other questions from the committee regarding this budget? I know it was pretty voluminous. Looking around. Majority Leader, go ahead.
Thank you, Madam Chair. And I want to go back and ask a couple of questions on the public option pieces of this, if that is okay with you, Madam Chair. Thank you. So we note that in here, and I know you answered a couple questions on the public option pieces, but in this budget, there was a recommendation to eliminate the funding of $2.2 million for 5 positions, and then additional revenues expenditures that relate to the public option and its implementation. I think there was a question that was asked about having that funding and personnel eliminated from the budget and whether that would affect the ability for the waiver to be submitted by January. Can you just delineate for us exactly what was taken from that budget item?
Senator Stacy Weeks for the record. Yes, there were, I want to say 5 positions that were eliminated, as well as funding for the actuarial support that was needed to support the negotiations for the 1332 waiver with the federal government.
And I think that is, I just wanted to make sure that we were clear about exactly what that would be covering, because Chapter 695K, which is the public option, which is statute in Nevada, which is law in Nevada, requires for this waiver to be submitted. We have heard that that waiver is going to be open for that public comment period starting in November, and will be submitted by January. Without those positions, in order to help with the actuarial pieces, how is the agency planning to absorb that work in other places so that it can actually get done? Because simply eliminating the positions doesn't eliminate the requirements that exist under Chapter 695K.
Senator Stacy Weeks for the record. We often in Medicaid get told to do a lot of work without the staffing, so I think we would just be absorbing that work and obviously always implementing state law, so we would have to follow state law and implement it.
What sort of impact, in addition to, because I know there were the positions that were eliminated, the waiver, as anticipated by the actuarial analysis, is anticipated to help the state bring in upwards of almost $500 million in the first 5 years, federal dollars that could come to the state that then could be reinvested in healthcare here to support other services or whatever the state might need in order to facilitate access to care and affordability for Nevadans. So I guess my question is, without those positions, how would the agency plan to be able to take in those dollars, to be able to monitor those? I mean, that's just additional work I think that we're hearing that the agency is going to absorb in addition to all the work that the Medicaid department is currently doing.
Senator Stacey Weeks for the record. Yes, you're correct.
And I guess this is more of a comment, Madam Chair, if I may. To me, $2.2 million to allow for them to have the personnel to implement this and to operate the public option trust fund and to have those positions rather than continuing to ask what we have repeatedly heard from many departments, including the very hardworking people over in Medicaid and Department of DHHS, which I know Director Whitley has, a number of employees who are doing 3-4 jobs all at once. To me, this seems like I struggle with what the reasoning is for eliminating what feels like a very small amount of money in comparison to even the rest of this budget and other budgets that we have seen, to allow for that personnel to be there so that, again, our hardworking state employees and all the folks over at Medicaid, they really are doing a very good job to make sure we have access to health care in a lot of ways, are able to do their jobs and not have to do the jobs of 5 and 6 people. So I appreciate your answers, and thank you, Madam Chair and committee members, for allowing me the time.
Seeing no other questions, if we can go ahead and you guys can go ahead and move on to 3160, the increased quality of nursing care.
Thank you, Madam Chair. All right, our next budget account is 3160. I did want to walk through this account, but just note that there are no major changes to this account and funding. But this account was established about 20 years ago under state law, and it sets up a nursing facility tax, similar to what we are seeing with our hospital tax, to serve as the state share, to match with federal funds, to increase payments to nursing facilities through supplemental payments. The tax revenue, like I said, is used to cover the state share, and the funds are transferred to our budget account 3243, which is our medical spend budget account. And there is a portion that we pull back for administrative cost for this effort. Again, no major changes. Are there any questions, Madam Chair, on that account?
I don't see any questions, so you
Okay.
can move on. Thank you.
Thank you. Our next account is 3177. This is our new account, Improve Healthcare Quality and Access. This is our hospital provider tax and payment program. It's established under state law, and what state law allows us to do is if a majority or 67% of a provider type, what they refer to as an operating group, vote in the affirmative to impose a tax on themselves, we can tax those entities and use that funding for 3 purposes. There's 2 that are related directly to supplemental payments to those very providers, in addition to administrative costs. So for the state. And as you can see here, we are planning to use that revenue if we poll providers and we have the authority. We will be using that revenue for 2 payments. The first here is the MCO directed payments to private hospitals. And the second would be our fee-for-service supplemental payments to private hospitals. And again, this tax would only be on private hospitals. But to ensure that we have the federal Medicaid match that we are able to capture that match for this revenue, we have to ensure that all private hospitals are taxed because it has to be broad-based under federal law. These funds, again, like the previous tax account, will be transferred to our budget for 3243 for medical spending, and a portion will be transferred to 3158 for administrative costs. I did want to share with members an updated timeline. Some things have changed since I sat in front of you, as well as probably in your notes when we gave LCB some updates. And these changes really reflect some of our capacity issues, to be honest, and just making sure that when we do stand this up, it's successful and that we're able to continue the payments we currently make, because we do have a backlog that we are working on right now. So I just want to note here that some of the timelines have been pushed back. As you can see, once we get through this session, and if the legislature and governor approve, sign, and everything is good, we have this new account, we will begin polling hospitals in June or July through that time period this summer, essentially, to see if we are able to get the agreement and authority to move forward. If we do, we are required by state law to issue regulations and guidance about what this tax will look like and how it will function and what the requirements for hospitals will be. We will be hosting in the summer and late summer all workshops and hearings around this effort. And then in August, hopefully we'll be done with that and be submitting to CMS for all approvals for payments. The effective date, we can always do a retroeffective date to the first day of the quarter that we submit the payment or the state plan amendment or the preprint to CMS. But right now, we're still determining what the right date is based on capacity. We're aiming for October to be a retroactive effective payment date, so any claims submitted after October would be able to receive the increased supplemental payments under this new effort. And then in January 1, we are planning to, and then again, this is optimistic. Hopefully this all goes well. Depends on CMS as well, too, as you probably know. But if all goes well, we'll be able to implement the new provider tax starting January 1, 2024. And the invoices would be submitted at that time to hospitals for the tax payment to pay us. And when we receive those payments, we would be able to issue the payment to the hospital. And we're planning to do that on a quarterly basis, similar to what we do today for our current supplemental programs. So in Q1, we would hope to have the first payments done and out the door. I'll be honest, our current program has a backlog, so sometimes this is slower. So we're hopeful by January 1, if we're able to staff up and support this effort, we'll be able to meet those timelines. But these payments are super important. I think, as you all know, it'll benefit more than 55 hospitals in our state. And then this is, I think, the last slide on this budget. It just shows you here what we expect to collect. It's a conservative estimate. We are, I think, doing a budget amendment to update some of these numbers based on current estimates, but this is a rough estimate of how much we expect to collect in state fiscal year 2024 in tax revenue, and then in state fiscal 2025. I would note that based on the most recent numbers we've ran with our actuaries, we expect that the payments out the door in total to private hospitals will be about $1 billion or more. And I'll stop there for questions.
Thank you. I think Assemblywoman Anderson has a question.
Thank you, Chair, and thank you for the presentation. I greatly appreciated the updates on the calendar. It feels very optimistic to me. So if you, I guess, how do I word this correctly? I mean, if you had to do a percentage, how certain are you that this can all happen by January 1st of just 8 months from now? It just, there seems to be a lot of notifications, a lot of discussions that have to take place, and already a kind of smaller staff. So just wondering how certain the department is that this is actually something that can take place by January of 2024.
Madam Chair, committee member Stacy Weeks for the record. A percentage that's a good question. I haven't been asked that yet. My concern is overworking staff, right? That is always my concern. And so I believe, though, in my staff and our staff as a division, and I do think I would say 75%, 80% certain we can get there. But I also want to recognize that if we burn folks out, we will lose. So I'm trying to manage that. And together we are doing our best. But I'm hopeful that we will get there and that this will be successful. I would note, though, that we will be adding, I mentioned earlier, additional staff that we'll need over the next year through the administrative spend that we'll get from the revenue from the tax. We do think from CMS's recent guidance about tax paid or tax funded payment programs in Medicaid, that we're going to need a new auditing team to audit hospital financials, because we are going to be held liable for any deals or any arrangements that hospitals have that violate federal law. So to protect the state, that is something we're very serious about, and I take seriously. And so I think building that team too over the next year is really important to me. So depending on how hiring goes and training and contractors, but I'm hopeful, 75, 80%, I would say, that we'll get there, because I will say we're small, but scrappy, and we have a lot of really hardworking people that work day and night. So thank you for the question.
Yes, go ahead.
So love the Hoosier story going on for that one as we start March Madness. As I look through some other notes, though, it sounds like there are some other partners that are also very interested in it. For example, the Nevada Hospital Association and others. Are they working with you currently to start maybe this process even earlier than this? Or do you have other partners that are also helping with getting this started earlier than just waiting until June and July, it sounds like, for some of these questions?
Madam Chair, committee members, Stacy Weeks for the record. We are working with them, but at the state, we have to represent the state and do the work ourselves and build it internally to ensure the state's protected. Mm-hmm.
And I have a couple of questions regarding the provider fee. You also have to maintain that 67%, and that's been a delicate balance as well. Is that my understanding? Is that correct?
Madam Chair, Madam Chair, Stacy Weeks for the record. I think so. I wouldn't want to speak for Nevada Hospital Association.
You haven't done that polling yet to see if there is the 67%.
Madam Chair, Stacy Weeks for the record, no.
And then, assuming that this went through, what is the agency's intended use of that 14.5% of that provider tax revenue? I think it's about $62.2 million. That's recommended to be held in that administrative reserve. Can you kind of explain that to the committee?
Madam Chair, Stacy Weeks for the record. Good question. We're actually in the process of doing a budget amendment to update that and kind of restructure how that's drafted, but I would say we're still working on how much administrative costs we need. Something we have recently realized that this does impact our state share cost to our medical spend budget for the cost of the premium tax. So we're also looking at what that means, and so I think we're setting a placeholder, knowing we may need less, a lot less. It's just we don't know until we get through all of the different analyses.
You had talked about needing an audit division or an auditor to make sure that the hospitals are complying with, that we're not in jeopardy as a state and holding those hospitals accountable if this went through. Would that be included in those administrative costs that came from that tax?
Madam Chair, Stacy Weeks for the record, yes.
Sorry, I just have a couple other questions here. Does the agency intend to take any action to allow for the state net benefit associated with the recommended private hospital provider tax program, given the potential impact on the new program and the state net benefit associated with existing supplemental payment programs? That's a lot.
Madam Chair, Stacy Weeks, that was a lot. We technically under state law don't have a state net benefit. So again, we're putting in a budget amendment to address that issue there. The net benefit, I think, would be our argument would be that it shouldn't cost the state any new money. It shouldn't cost our program. We shouldn't have to work, more positions to do this work. So I think, our argument is, and what's allowed under state law is to cover the administrative costs, and we're still determining that.
So you want to make sure that the billion extra dollars that goes into the private hospitals as a part of their paying this fee is a cost benefit, I guess, to the state.
Madam Chair, Stacy Weeks, for the record, no, we can't, under state law, have any benefit as long as it doesn't cost us. Yeah, net neutral.
Net
right?
neutral.
Yeah, to cost, yeah.
And then how would the proposed private hospital tax program actually improve care or access to care for Medicaid recipients?
Madam Chair, Stacy Weeks for the record. So the assumption is if we increase provider rates, providers will more likely be able to serve our population. Also, I think we all know, especially in our rural areas, that hospitals are struggling to make ends meet. So hopefully this will help keep the access we currently have and sustain that and not lose providers. I think it's a little bit of both. It's sustaining access that we currently have that we possibly could lose in the next couple of years as cost increase. I mean, the reality is as inflation goes up, private market goes up, and somehow Medicaid as a taxpayer-funded program is supposed to keep up. So this allows us, I think, to help those hospitals where often we don't have the state funds to do that.
Do we have any metrics or anything currently in state law, because I know this has been an existing law for quite some time now, that are able to measure the success or that increased quality or access to care with these provider fees?
Madam Chair, Stacey Weeks for the record. Yes. So one of the payment programs under federal law does have a quality metric requirement, and I call it the quality component. States have done this differently. I think we're really looking at having, at least in the first year, one metric per hospital subclass that we would be monitoring to see if they're improving. Obviously we wouldn't withhold payment because some of these hospitals really need the funding, but it is something that we will be monitoring and are required to monitor and report to CMS. And we're looking at posting those findings online.
Thank you. I think Senator Severs-Gansert indicated she had some questions as well.
Thank you, Madam Chair. When I was looking at the notes here, the anticipated numbers for 24 and 25, they were both 286, 150 million, but your slide's at 388 for fiscal year 25. So I don't know if there was an increase in expected funds in fiscal year 25 versus what we had. We were looking at like 572.3 million over the 2 years.
I think we have an answer here from staff.
Oh, okay.
Thank you, John.
Go ahead.
Senator Gansert, John Kucera, LCB Fiscal for the record. The difference there is the reserves that are requested in the governor's budget,
So you're carrying the
separate
reserves.
from the revenue source.
Okay, thank you. And then to follow up on when you made a comment about the state becomes liable for any laws or anything that's not followed at the federal level. All the hospitals go through accreditation processes, and I don't know if that's strictly just for quality of care, if that's also to make sure the boundaries are provided. Does that give us any comfort, I guess, because they have to go through accreditation processes for different types of care?
Madam Chair, Stacey Weeks for the record, no. What we're talking about are making sure that there's no hold harmless agreements amongst hospitals. Also that the amount of claims that they're reporting around, for example, if we have to use their data for average commercial rates, so what we're basing our payments on, if that's data is accurate. So it's really looking at their financials that we don't currently see and understand. I don't think we'll be auditing. Honestly, I don't think we would have the capacity to audit everyone every year. It would just be at random to check in to make sure that there's nothing that would result in the state owing money back to the federal government.
Okay, thank you.
Mm-hmm.
Senator Cannizzaro.
Thank you, Madam Chair. I know we've talked a little bit about some of the positions and the audit pieces, and I know that we also just, even last night, heard at Legislative Commission that there were some audits regarding Medicaid payments and overpayments and some significant issues there with how that is being managed. So do you have, can you talk just a little bit more about whether you have sufficient financial and audit positions to be able to monitor those MCO contracts and the payments that are going out? Because I think that really does play into what we're seeing proposed here with the provider tax rate, and just whether or not there's sufficient staff to do that, because we did just get, like I said, that audit report that showed some very concerning details that I think we'll probably just want to clarify.
Madam Chair, Senator Stacey Weeks for the record. I will say there are 2 new positions in that program that for the statewide managed care work, and those are really important to being able to provide that oversight. We are doing other things internally to restructure how we monitor and oversee our contracts. Teresa Karsten, who is our new deputy over that program, is very good at that work, and I'm hopeful that some of the things that we haven't been able to do in the past, especially if we get these 2 positions, we'll be able to do, and as we increase the program, we'll be able to keep up.
Great, thank you. And one more question, if I may, Madam Chair. I know you asked about the improvement to care and access to care for Medicaid recipients. The other piece I wanted to ask about, because as I'm looking at this budget detail, there's not a piece of this that is specifically dedicated to community investment or how it is that we might be using some of these funds to help with other programs to make sure that we're having more robust healthcare here in the state, more access to different services. So why is that not included? Has that been a point of discussion? I think that would be an important piece to see here, given the revenues that would be coming in, and how this is really supposed to be directed at making sure that we can continue to provide some increased access here in Nevada.
Madam Chair, Stacey Weeks for the record. Currently, state law limits that this funding be used if the poll occurs and the votes are there. That any of the funding has to go back to those hospitals under state law and administrative costs. So, if lawmakers and the legislature and the governor want to see changes in that, that would have to be a state law change.
Okay, great. Thank you. Thank you, Madam Chair.
Do we have any other questions regarding this particular budget? Seeing none, I will let you move on to 3178, the Nevada Checkup Program.
All right, we're making good time. Let's see. So the Nevada Checkup Program. So this fund, 3178, collects funding for the Checkup Program, which is the state's Children's Health Insurance Program, which is a federal program under the Title 21 of the Social Security Act. CHIP provides federal funds to support low-cost coverage for uninsured children ineligible for Medicaid whose income is at or below 200% of poverty. As I mentioned previously, families pay a quarterly premium based on the family size and income. Currently, there are about 21,832 children enrolled in this program. This slide reflects various provider rate changes in the governor's budget that impact the Nevada Checkup Program. The first, as you can see here, are specifically related to specific inflation. Sorry, got off my notes here. Hold on, please. Sorry. Okay, so these are related to, like I mentioned earlier, healthcare costs and inflation keep going up. Some of our rates and some of our payments are based on cost. And so we have to assume that some of these rates are going to go up, even though we're not quite there yet. So this reflects some of that specific inflation that we expect for pharmacy, hospice, federally qualified health centers, and rural health centers. Also, the federal government sets the rate for Indian Health Services, so it does reflect some of those changes. And then down here at the bottom is our adjustments to the base that reflect funds adjustments to include the elimination of one-time expenditures for equipment and other partial year costs for continuation of programs. This slide here reflects some of the changes you saw earlier in the graph. The first one funds a decrease in the projected average monthly caseload from 23,000 in fiscal year 2022 to 22,000 in fiscal year 2023. And then below is an increase. So this funds an increase in the projected average monthly caseload from 22,000 to about 24,000 in fiscal year 2024. So some of these next slides you're going to see in our Medicaid budget. So some of the changes that we're making impact both programs, right, to improve access. The first here are provider rate increases that the governor is recommending. The governor is recommending a 5% rate increase for physicians, and that's all physicians licensed in the state of Nevada. This request is a companion to, and we'll talk about it in a minute, E-130 in the Healthcare Financing and Policy Administration budget. The other item here funds a 5% rate increase for dentists. And as you guys know, access in both of these areas are really important. And so the governor is recommending that we increase the rates for these providers. The next slide, I think, also deals with some of our changes in our checkup program. I am probably going to skip these here, if that's okay, and pick them up again later in the Medicaid budget because there's a little more detail there and we can discuss there and a little more on the costs. But we're making the same changes that we're making on these programs in our Medicaid budget. And we'll get there in just a second. And then this last one we'll go ahead and talk about now is the elimination of coverage in Medicaid for in Nevada Checkup for biofeedback and neurotherapy. These services were initially proposed and passed during the last session in an effort to reduce current cost to the Medicaid program. It was related to some budget cuts that the program had. These services were recommended by the division because we saw a high volume of investigations around fraud and misuse of these services due to improper billing. So in the effort to come up with new spend and to cut costs, this was something that was recommended and passed. We would have already implemented this, but federal law prevented us because of the public health emergency. We were under a maintenance of effort requirement, which means that we had to maintain all current benefits, all eligibility until this ends. And so now we're finally able to implement this, this change. So you'll see that here reflected. I'll stop there, Madam Chair, and see if there are any questions on those, or we can dive into the Medicaid budget.
There are. I think we have a question from Senator Titus.
Okay.
Maybe? Nope. Nope, sorry. Well, I will go to, how about Senator Sievers-Gansert?
Thank you, Madam Chair. So I just wanted to look at the autism, the behavioral analysis rates. There, we have an attachment which shows the different rates, and some of them are decreasing anywhere between like 2.7% to 42%. And I know the net to this budget is not that great because some are going up and some are going down. But what do you think the impacts are going to be as far as delivery of services to children with autism when we're cutting some rates like 42%?
Madam Chair, Stacey Weeks for the record. Senator, that's a very good question. Obviously, anytime you cut rates, I mean, you do have to worry about access. So I think that's a given. I would just note that we are required under state law to make these changes. There was a bill passed last session, Senate Bill 96, that required us to look at these rates biannually. So every time we come in front of you, all the ones that are paid through fee-for-service, and to adjust them to make sure they're comparable to rates paid in other states. So as other states are changing their rates, now we're changing ours. So these changes reflect that legislation. They're just now being implemented because, like I mentioned earlier, we were under a maintenance of effort requirement.
Okay, just to follow up, I mean, when I look at where you're trying to move, it's the median, and I mean, it seems like there would be some discretion in what level you choose to compare them to. And what's the total dollar deduction? Because you netted about even, but how much are we not putting into the services that are being reduced? So the negative number.
Madam Chair, Senator, I'll have to get you that number.
That would be helpful because I think many of us are concerned about access to care, and it sounds like we do have statute that says we're supposed to adjust them, but it doesn't really say to what level. It says to compare and to adjust, but I think there's probably some discretion there, and there would be concern about losing services for children with autism if we reduce some of the rates at the levels that are proposed here. And I think that's one of your part of your mission statement, right? To make sure that we get care, quality care to Nevadans. Thank you.
Yep.
Any further questions on this budget? Go ahead.
Okay. All right, so let's move to 3243, Nevada Medicaid budget account. This is our medical spend, so it's our big account. It collects funds to cover the state share, to cover the cost of providing health care to recipients. Because Medicaid is an entitlement program under federal law, when Nevada Medicaid adds a new benefit, the state must budget for this service and cannot deny reimbursement due to any budgetary concerns. That's kind of the deal we make with the federal government. For example, any benefit or service added as a Medicaid covered benefit must be paid for, if it is provided by a qualified enrolled Medicaid provider and delivered to a recipient in a manner consistent with Medicaid policies. This means that the state must pay its portion of the bill, regardless of how many people we seek. And so this account represents how much we're projecting we need. Every year we're looking at updating this, and we use our caseload to project and look at medical spend and come up with budgeted medical expenditures, and that's what you see here today. The table here is just a visual reflected in the chart, and it reflects all expenditures in 3243 from 2015 to 2023, including fee-for-service medical expenditures, managed care payments, supplemental payments to providers, and other related services and expenditures. The first slide here represents just some of our caseload changes and some of that inflation I mentioned earlier and adjustments to provider rates. The next slide walks through some of these changes in our waiver program. As I mentioned in the last hearing, the pre-session hearing, the governor is recommending some changes to the program, but these here are just the caseload changes. And the next slide actually are increasing slots, so allowing more members to access our waiver programs, which are the home and community-based services that we provide for individuals with intellectual disabilities, the frail and elderly, and people with physical disabilities. And as you can see there, each waiver is increasing a number of slots. The first one is 519 slots for individuals with intellectual disabilities. The frail and elderly are increasing 250, and then those with physical disabilities, the slots are increasing to 96. The next slide represents some of our the governor's recommended changes to increase enhancements for behavioral health. The first, E800, is our Children's Behavioral Health Initiatives. This funds the ongoing children's behavioral health initiatives implemented by our sister division, the Division of Child and Family Services. This includes specifically some staffing and admin costs. We're helping match that with federal funds to support some of their efforts that they set up for with some ARPA funding. And the next item here is 370. That is the Certified Community Behavioral Health Care Center expansion. This item funds the expansion, like I mentioned earlier, from 9 to 15 providers. We're hoping that will really improve access to behavioral health care in a way that's integrated with primary care and substance use services. This slide here walks through some of the same rate increases I talked about earlier in the checkup program. The governor is recommending the same rate increase for physicians and dentists in the Medicaid budget. The governor is also recommending, and this is the same thing in the Nevada checkup program, that we fund some of the provisions that were passed last session to allow APRNs and midwives to receive rates equal to physicians. We've seen in other states that by doing this improves access and increases more of these services, especially in our rural areas. Provider rate increases continued on the next slide. E126 has to do with a rate increase that was recommended. Let me get to the right side. By the Home Care Employment Standards Board. They would like to see that rates go up to $25 an hour. This is funding how much that would cost and how much we would pay the providers that provide these services. However, the PCAs that work for these providers would have to ensure that that they use these funds to increase wages. I just want to note that this doesn't necessarily mean that everyone will get at least $25 per hour, that this would still be up to the provider who employs these individuals. Skilled nursing facility rate increases. This funds a 5% rate increase for our skilled nursing facilities, and this comes from some of our quadrennial rate review and looking at the needs for these providers. And this last one here is related to a rate increase for intellectual disability providers, for individual intellectual disability providers. As you can see, the total cost increases in that next year. All right, move to the next slide. And these are some of the new benefits and expansions on eligibility is the first one. So the governor's recommending an E364, expansion of eligibility for pregnant women from 165 today % of poverty to 200% of poverty. I would note that majority of states do cover pregnant women up to 200% of poverty or higher. So this will be bringing us up to some of the standards nationally. I would also note that here, the second item, E227, is the coverage of cardioverter defibrillators and supplies. Nevada is one of the only states that does not cover these services, and these are pretty life-saving devices that individuals can wear and avoid having to go ER and hopefully save their lives. So we are joining everyone in the nation in adding this to our program for coverage. And the last item here, dental benefits for individuals with intellectual disabilities. This funds some of the dental services to individuals diagnosed with intellectual and developmental disabilities, age 21 and over, who are in our waiver programs. This was funded originally with ARPA funds, and this continues this program. I will say we're really excited about this program, and we find that often individuals with intellectual disabilities have a hard time finding a dentist, and we don't cover adult dental, I think, as all of you know. And some of these individuals, their dental needs are very serious, and some of the cost to dentists to provide these services can be high because often they'll need anesthesia and other things that are needed to provide them safe dental care. And so this new benefit really is focused on that and ensuring these individuals get the dental care that they need. So, and we just had, started this program, so I'm a little excited about it. Our dental health officer's been working on this with our sister division, ADSD, and we just served two new people with the ARPA fund, so we're excited to see this program grow. And then some other enhancements. We just talked about the ABA provider rate increases. As I mentioned, the division was attempting to implement Senate Bill 96. And like I mentioned earlier, we reviewed other states. In fact, we've reviewed about 25 states and looked at the median rates for each code and provider type. And so you'll see there's, like you mentioned earlier, that there are some increases and decreases, and so a net overall decrease to spend for this population. The last enhancement here is for the non-federal share. So this actually reflects the payments that are going to be part of the new hospital provider tax. So as you can see there, this is the non-federal share of the new private hospital tax that comes through this account that I mentioned earlier to pay for and draw down federal share. All right. I think we're almost to the last slide. So this last one here has to do with, I mentioned earlier that the second enhancement reflects the budget impact of changes to the DISH funding model and also the Clark's contribution and FMAP. So this last one here, let's talk a little bit more about it. The goal of these changes to the DISH program were to ensure viability of the DISH program and other hospitals and ensure that other hospitals benefiting from the DISH payments today see no changes in their distributions. But the key here was to address some of the concerns and the viability raised by Clark County and UMC. As I mentioned earlier, because UMC had seen a reduction in uncompensated care, thanks to some of the efforts in Medicaid and some of the expansions we've seen, their DISH payments were capped and they had to repay about $30 million annually. Under this proposal, instead of having Clark County put up the IGT, the state is going to be using 1 cent property tax, the ad valorem, paid by counties to help fund the state share of the DISH program. The state is required under federal law to pay something toward the DISH program. So this is our attempt here, as you can see some of the state general fund impact, to ensure that the budget is picking up any of these changes and ensuring that there are no losses to any hospitals. And as I mentioned earlier, that some of the losses to UMC are being offset with new IGT investments by Clark County into our state-directed payment programs through the managed care program. And I would just note that the ad valorem tax is about $13 to $14 million per year. I'll stop there because I think we have one more account, and I'm sure there are a lot of questions on this account, so I'll stop.
We do. We have all the questions from all the people.
I
So I will go ahead and start with Senator Titus and then be followed up by Assemblywoman Gorlow.
Great. Thank you, Madam Chair, and thank you for that lengthy presentation. I thought it was pretty clear, and I know it's a lot of effort goes into this. We need to back up a little bit and go, and it's consistent with my question of the unwinding. So would you kind of give us a little bit more on the expectations regarding the caseload returning to pre-pandemic levels following the unwinding of the COVID-19 public health emergency? During the presentation, we talked about initially in 2021 and 2023, there were over expectations of the caseloads, and now we're going to cut back on that. Where are we in that process?
So currently Madam Chair, Senator Titus, Stacey Weeks for the record. We have not started unwinding yet. So it begins in April. We'll start some of that process. That's now we're required under federal law to start. So no more extensions. And then in June, I think we'll start to see by then the first round of people actually dropping off, and we'll be able to check to see if our caseload projections were accurate. And we'll be doing that every 3 months, it looks like, because that's the cycle of the redistribution.
So a follow-up on that, Madam Chair?
Go ahead.
So what you presented was probably a change of about 2% less. Is that still within what your expectations are?
Madam Chair, Senator Titus, I think so, but I'll follow up on that to make sure.
Great, thank you, and thank you, Madam Chair.
No problem. Assemblywoman Gorlow.
Thank you, Chair. Thank you, Chair. I wanted to go and talk about the waiver wait lists. Currently, there's wait lists for the individuals with intellectual disabilities, frail elderly, and persons with physical disabilities. And it's my understanding that that wait list is 3 months or longer. So can you discuss the contributing factors to the wait list for the 3 waiver programs, and what is the average wait till somebody gets services?
Madam Chair, Senator Stacy Weeks for the record. We do expect that this will help, these slots will help. I think also, though, there is a challenge because of the lack of providers to serve these individuals. I think, we can add slots all day, but if someone doesn't have somewhere to go to receive that service, it's still a challenge. So I think it's something we're going to be looking at and tracking. I'll have to get back to you on your last question. I want to make sure I talk to my colleagues at the Division of Age Services and ADSD is what I call them easily. They'll have some of that more information on the wait list for you.
Thank you for that. And when you talk about a lack of providers, is it a lack of a provider nearby, or is it that we just don't have someone to fulfill those services?
Madam Chair, Senator Stacy Weeks for the record, it's both.
And I think next up we have Senator Dondero Loop.
Thank you, Madam Chair. And can you discuss how those increased rates of reimbursement for the physicians and the dentists and the skilled nursing facilities will increase the access to care for the Medicare recipients?
Madam Chair, Senator Stacy Weeks for the record. Today, a lot of providers, especially those that hang up their own shingle, often struggle if they're serving a lot of Medicaid enrollees. And if you think about 1 out of every 3 Nevadans being enrolled in Medicaid, that is a big portion of probably most providers' patient revenue. And so increasing these rates helps sustain some of the current providers, but also encourage more providers to be able to think that they could hopefully be able to support their budget and offer these services.
Thank you very much. Follow up, Madam Chair. When you talked about some of our disabled people not being able to get dental care services, it made me think of the dental care in general. And a lot of times they'll pull teeth instead of fixing them. And so with disabilities, that can even cause more problems. So I was wondering if there was any discussion about that and how we might need to move forward so that we can help our disabled people, but all people who may have Medicaid and not be able to get those dental services.
Madam Chair, Senator Stacy Weeks for the record, yes, that is a big piece of this, and it's a big goal. We have a new dental health officer, Dr. Keith Benson, who's been working very closely with the other division who oversees the waivers, but also providers that are providing these services to ensure that the services that they're getting are the ones that they need and not going to result in more problems. But that is the goal here, is to ensure that these individuals have better care.
Thank you. I think that's probably one of the important things that we need to look at. And so I appreciate you not only being excited about that, but
yes,
answering the question. Thank you.
And I'm going to bounce around here a little bit. I'm going to go to Assemblywoman Monroe Moreno, and then to Senator Severs Gansert, and then back to Assemblyman Watts.
Thank you, Madam Chair. My questions are going to be on the personal care services E126. There was a recommendation from the Home Care Employment Standards Board that discussed the $25 rate increase. Could you let us know what was the methodology that was utilized to determine that $25 reimbursement rate increase?
Madam Chair, committee member Stacy Weeks for the record. I'll have to get back to you on the actual methodology. I'm not quite sure there was one. I think it was just something that was thought would be helpful, but I want to make sure and ask my colleagues who sat on that committee and get back to you.
Thank you so much for that. And then along with the recommendations, there was also a recommendation that the personal care services that were provided, those people actually doing the work, got a wage increase with a minimum of $15 an hour. Have there been any actions taken to move on that recommendation, and how would you enforce that recommendation? We know that they're the ones that are on the ground in the homes doing the work and deserve to to get that raise. Can you tell me what's going on with that?
Madam Chair, committee member Stacy Weeks for the record. I'll have to follow up with you on that. I think the goal here was to try to get at some of that issue, but again, the providers will have to actually pay their individuals more with this funding to make it actually happen.
Madam Chair, follow up? Is there anything more that we need to do to ensure that once that funding increase happens for the agencies, that that money is actually given to the providers providing the services in the home?
Madam Chair, Stacy Weeks for the record. In other states, states have added statutory language to require that the funding be used, a percentage of the funding be used for wages and benefits.
Thank you for that. Thank you, Madam Chair.
I kind of have a follow-up question, actually, before I go to you, Senator Severs-Gansert, regarding that. Does when the department contracts with these, what are they called? The home care employment, like, I guess, these agencies, do they set in those contracts when they're doing that, the ability to set minimum hourly rates or any of those things in the contracts when they're contracting?
Madam Chair, Stacy Weeks for the record. I'd like to bring up Deputy Dr. Capurro to see if she might know that answer offhand. I don't want to speak incorrectly on that.
Thank you. I appreciate that.
Good morning, Dr. Capurro for the record, Division of DHCFP. So we would enroll the personal care service providers as any other provider type. So we are not directly contracting with them, we're enrolling them. And then they would pay the home care employees directly.
So as a part of that enrolling them, there isn't any like requirements. It would take a statutory change to require a percentage of that fee that we're paying them to go to the actual providers?
That's correct. So we don't set any standards between the employee and the employer.
Thank you. And Senator Severs-Gansert?
Thank you, Madam Chair. I want to circle back to the dental care for the adults with intellectual or development disabilities. So in your budget, you have a cap of $2,000 per individual, and it looks like you maxed out the dollars that you placed in your budget, so there was an assumption of 100% utilization. Do you think that 100% will be accurate, or do you expect there's going to be some sort of phase-in for the use of the services?
Madam Chair, Stacy Weeks for the record. Senator, I'd like to call up Dr. Keith Benson, even though I promised him I would not call him up here. He's our new dental health officer, and to help me answer that question.
Thank you.
Thank you.
For the record, Dr. Keith Benson with DHCFP, and I'm the state dental officer. Could I ask to repeat the question, please?
Sure. It's a long hearing. So in looking at the dental benefits for the adults who have intellectual or developmental disabilities, the budget item actually is priced out at $2,000 per person for, I think, a caseload of 5,247. And so there's the budget amount that was set aside is for 100% utilization. So do you expect 100% utilization of the $2,000 per individual within this budget?
Dr. Keith Benson, for the record, and through Chair to Senator Gansert, the fees that we are providing for these folks, dentistry is costly, and so I expect that most of the $2,000 will be spent per patient. It depends on need. I'm expecting a lot of these folks have not received dental care because before this program, they really weren't receiving comprehensive benefits, and now we are providing those comprehensive benefits, everything from cleanings and root canals to partials and dentures. And so if we can find the right providers with the right patient, I think we could easily complete that $2,000.
Okay, and so this program was originally started through ARPA, it was an expansion, and so this is really continuing that expansion. But do we have more dollars in the pool to be able to help people? Is that part of what we're trying to accomplish?
Keith Benson, Dr. Keith Benson, for the record, through you, Chair, to Senator Gansert. So I believe that we're going to try to increase from $2,000 to $2,500 within this program as well. And so, yes, trying to provide as much care as we can.
Madam Chair, Senator, I would just add that the goal here is to draw down federal share to help match some of these funds and make sure that as we look to see how many people use these services, if we come back next session, right, and explain sort of the phase-in approach. But yes.
Yeah, I think we're excited about this program too. I think we're just trying to figure out for budget purposes whether we budgeted enough money. Thank you.
Yeah, thank you.
If we can go to Assemblyman Watts.
Thank you, Madam Chair. So I have a couple of questions related to the reimbursement rate increases, specifically those for the community-based services for individuals with intellectual disabilities. How would the recommended rate increase impact access to care for individuals on in that program?
Madam Chair, Stacy Weeks for the record. Assemblyman, again, I think the hope is increasing rates will improve the number of providers that take these individuals and provide services for them.
Thank you. So do we have any kind of estimation of what that impact will be?
Madam Chair, Stacy Weeks for the record. We do have probably some estimates around utilization. If that's helpful, we can follow up with that to the committee members.
Thank you. That'd be great.
Yep.
Madam Chair, may I have one more? Thank you. I also wanted to ask a question about the APRNs and that reimbursement. Could you discuss how this proposal compares to, or how our current rate compares to neighboring states, and how this increase would then compare, and how that may increase access to care?
Madam Chair, Assemblyman, Stacy Weeks for the record. I'll have to follow up with you on that. I don't know offhand the rates of APRNs in other states.
Thank you. That'd be great. Thank you, Madam Chair.
Thank you. If I can go to Assemblywoman Gorlow.
Thank you, Chair. You've mentioned several times with these rate increases that the goal is to have more providers care for these individuals. So my question is, what is the process for, whether it's a physician, a dentist, APRN, what is the process of them becoming Medicaid approved, and how long is that process usually?
Madam Chair, Stacy Weeks for the record. I think it depends on the provider. I would like to call up Deputy Administrator Sandy Rubila to talk a little bit about our provider enrollment process for you.
Good morning. Thank you for the question. Sandy Rublit for the record. The provider enrollment process is largely driven by CMS regulations and rules. It is complex, and it is time consuming. It is something that is a priority for the division that we're working on. We are implementing, excuse me, a centralized credentialing process, which we hope to improve that time frame. And we are continually looking at the process to try to make it less administratively burdensome for providers.
Go ahead.
And is there any cost to the provider to become Medicaid approved?
Thank you for the question. Sandy Rublit for the record. CMS does have a process where you can charge a fee. Nevada has a waiver to not charge a fee.
We can go to Assemblywoman Howdiggy.
Thank you, Chair. And I want to go back to just follow up on the questions you were asking under Decision Unit E126, the home health care workers. And I believe you had asked, and Dr. Capurro had answered that the division doesn't set the standards between the employer and the employee on how much of that increased reimbursement goes down to the employee. And I don't know if this is a question that division can answer or more of a question for our staff, but how do we set those standards? How do we go about, if we are increasing the reimbursement rate, that some of that trickles down to the home health care worker and just doesn't stay with the employer? I'm not sure who's best equipped to answer that question.
Madam Chair, Senator, I was looking at John Kucera, see if he wanted to answer it. I'm not sure about necessarily if this is the right way to do it in Nevada, but I've seen in other states that they have just put in that there is a portion of this funding that providers have to agree to give to their employees.
Follow up, Madam Chair? So,
Go ahead.
so is that done in the budget, or is that done by statute, that if we increase the reimbursement, that a certain percentage of it has to trickle down to the home health care worker or to the employee?
Madam Chair, Stacy Weeks for the record. I would advise to talk to your counsel about the best way to make sure that's represented.
Okay, thank you. Thank you, Madam Chair.
No problem. And I think, do you have any clarification, John?
Thank you, Madam Chair. John Cusero, LCB Fiscal for the record. Medicaid largely operates with a pool of funds available to provide the array of services as legislatively approved. So, for example, there are several decision units within the Medicaid budget account 3243 that add general fund and federal funds to enhance, for example, dental services for 5%. Those funds are estimated. The general fund and federal funds are included in the budget, and then Medicaid is allowed to go forth, request federal approval through the state plan amendment process. However, the legislature does not typically approve very specific rates for services outside of adding authority to the division's budget. Hopefully that provides some clarification.
Thank you. Any other follow-up?
I can take it offline.
Okay.
Thank you.
No, I understand. Thank you. If we can go to just up and next on the line to give people on the committee members a heads up, Assemblyman Hafen, and then to Assemblywoman Gorlow and Assemblywoman Dickman.
Thank you, Madam Chair. I want to go back to the changes made in Senate Bill 96 from the 21 session. During the testimony, it said that 63% of the providers were unwilling to serve Medicaid patients related to the applied behavioral health services. So with the increase that came out of SB 96, what kind of impact are we seeing for access to care to the Medicaid participants?
Madam Chair, Senator, or Assemblyman, sorry, I can't see today, Assemblyman Stacy Weeks for the record. We haven't implemented this this bill yet, or this statute yet, because of the maintenance of effort requirements. So this would be the first time we would be making these changes if approved.
Do we have any projections of what the impact will be?
Madam Chair, committee members, I can follow up with utilization counts. Yep.
Thank you. And if we can go next to Assemblywoman Gorlow.
Sorry, I'm frantically writing notes. And you may have already covered this while I was writing my notes. What quality or outcome data was utilized to determine the Certified Community Behavioral Health Center program should be expanded?
Madam Chair, Stacy Weeks for the record. I'd like to call up Deputy Administrator Teresa Carson to see if she can help with that answer.
Deputy Administrator Teresa Carson for the record. I unfortunately don't have that information available to me right now, but I'd be happy to follow up.
Go ahead with your follow-up.
Thank you. I appreciate that follow-up. And then I wanted to talk about the eligibility expansion for pregnant women. I love that we're going to 200% the federal poverty level, but I noticed that it's a 60 days for postpartum. Have you guys done any calculations on what that would look like to, say, a full year?
Madam Chair, Senator Stacy Weeks for the record. We do have some estimates around postpartum, but it's not part of the current governor's budget recommendation. Do you have that with you? Okay. We can follow up afterwards, though, with our previous analysis on that, if that's helpful.
Thank you very much.
I was just going to ask that, so thank you. I think next up we have Assemblywoman Dickman.
Thank you, Madam Chair. And talking about the expansion for pregnant women, I was just wondering, how will these people be made aware of this expansion? Do you have a plan to inform?
Madam Chair, Stacy Weeks for the record. Yes, we do have some outreach. We do so we do have social media, and we do some announcements to providers, especially our provider network is really important in this effort to ensure that individuals who may be eligible are notified, but also when people go to the exchange, for example, they will be now told possibly that they're eligible for Medicaid. So depending on when they seek coverage, they will be notified.
So someone who wouldn't normally be getting that type of coverage may not know or hear?
Madam Chair, Stacy Weeks for the record, yes.
Okay. Thank you. Thanks, Chair.
Thank you. I have one question as well. Can you discuss the impact of eliminating the neurotherapy and biofeedback services to the Medicaid participants who currently receive those services, and how their continuity of care will be maintained now that that's been eliminated?
Madam Chair, Stacy Weeks for the record. Yes, we do think there are other services that we currently provide that will provide similar results for these patients, that they are still covered, and I can follow up exactly what those services are afterwards.
I would like to see that. Anytime we're cutting services,
I know.
obviously that gives me some heartburn. So if we could follow up with what that looks
can do
like for
that.
those particular patients, that'd be wonderful. And I think, look around here one last time, see if there are any, yes, we have Senator Titus.
Thank you, Madam Chair, for the indulgence of another question here. So we talked about the expansion of the postpartum coverage. One thing I haven't heard in any of these presentations is the coverage for presumptive eligibility and what those figures would look like. Because what we're trying to do is actually save some money here, and we've discussed multiple times that we know prenatal care lowers the cost overall. They don't end up in the NICUs. It's just better overall for the mom and the babies and for the society as a whole. So I'm wondering, is that somewhere else in the budget? Are you going to talk to us at some point regarding that presumptive eligibility piece and what that might look like and the cost of that?
Madam Chair, Senator Stacy Weeks for the record. Well, I have some good news for you. We currently are doing that work, and we are implementing that now, the presumptive eligibility for pregnant women with more providers. We also are required to have presumptive eligibility in all hospitals that are in Medicaid, and we do that today. I would just call up Deputy Administrator Dr. Capurro to help walk through our implementation of the pregnancy, our presumptive eligibility for pregnant women.
Good morning. Thank you for the question, Dr. Capurro, for the record. If it would be helpful, we can follow up with our implementation plan in writing. We have conducted public workshops and are working with our sister agencies to implement that. We also are in communication with CMS on our state plan amendment and have received just some recent feedback. So I think it would be more helpful to follow up in writing on that question.
Thank you for that, because it's something that one of the few things in my 5 sessions that Assemblywoman Carlton and I agreed on, and we'd love to see some follow-up on that. So thank you.
I hope she's watching. Do we have any other questions? I know this was a pretty lengthy budget. I know there are a lot of other questions, so if you do, please follow up offline. With that, we will move to our last and final budget for today, 3245. Go ahead when you're ready.
Thank you, Madam Chair. So this budget account collects our rebates for physician outpatient facility administered drugs and drugs sold through pharmacies for Medicaid. It also collects rebates for drugs covered by our managed care organization. As you probably know, Medicaid can only reimburse for drugs if the manufacturer participates in the federal drug rebate program. This program was put into place to address some of the costs that were state Medicaid programs were seeing around paying for drugs. And as you can see in your budget materials, that the estimated collection annually is about $416 million that we're estimating for this program ongoing. And I don't have any major changes other than that to mention.
I think we have one question from Assemblywoman she did. I saw that. I was going to say, if you still had it. Do we have any other questions from the committee? Well, thank you so much. I know you guys tackle so much outside of this building, and we definitely appreciate all the hard work that you put in to these presentations and helping us get through them and answering all the questions. So with that, I will close the hearing on these budgets, and we will move into public comment. I will remind everyone that public comment is limited to 2 minutes. And if there is anyone in the room here in Carson City, I'd ask you to come to the table, and reminder to state your name for the record and begin your testimony when ready.
Thank you, Madam Chair. Good morning. My name is Sarah Adler. I'm with Silver State Government Relations. And I today am before you representing NAPNA, Nevada Advanced Practice Nurses Association. I think that's right. Yes. And so both Senator Dondero Loop and Assemblyman Watts asked about access to care, the change in access to care through these improvements in rates. And through Nevada Nurses Day, I met Julie Coop, who is an APRN in Winnemucca. She is the only APRN who provides Medicaid assisted treatment out in a huge piece of rural Nevada. And she said, if I don't receive these rates increase and reimbursement parity, I will not be able to continue to provide this care. So that's just a very poignant example of the importance of the rates to APRNs. So thank you very much.
Madam Chair and members of the committee, for the record, my name is Brett Salmon with the Nevada Healthcare Association. Our association represents the nursing facilities and assisted living facilities throughout Nevada. I'm here to highlight the important needs for adequate reimbursement rates for nursing facilities in our state. Excuse me. We're very appreciative that the current Division of Healthcare Finance and Policy budget contains a line item for a proposed rate increase for nursing facilities, and in the coming weeks, we'll be visiting with many of you to discuss additional proposed funding to further close the gap between the reimbursement rate and the actual cost to deliver care to our nursing facility residents. Nursing facilities have had only 2 Medicaid rate increases in the past 20 years. Our facilities deliver about 1 million Medicaid days of care to our residents each year, which is about 60% of the care that we provide is for Medicaid residents. And nursing facilities are an incredibly important part of the healthcare continuum, and when you don't have a healthy part of that continuum, it impacts everyone else. And nursing facilities have to do a delicate balancing act when they admit their residents. They have to focus on the care, whether they can safely care for those residents, and then they have to focus on the financial side. And that's the side that I'm focusing on today as far as the reimbursement rates. As they will admit a resident, they have to decide whether they can take a Medicaid resident, or a Medicare resident, or a private pay resident, and the Medicaid is always the lowest payer, and so there's a balancing act that happens there after they determine whether they can safely care for that resident, and that balancing act sometimes creates bottlenecks in the systems. And as a result, other providers that want to admit to a nursing facility or hospitals that want to discharge to a nursing facility sometimes can't do it quickly, and they have to hustle around to try to find other places where they can admit those residents, and as a result it increases the costs in the system and slows quality care for our residents as well. So I encourage your support for an adequate reimbursement rate for nursing facilities. Thank you.
Seeing no other people at the table for public comment here in Carson City, I don't see any in Las Vegas. BPS, if we can go to the phone lines, if there's anyone in public online.
Thank you, Chair. If you would like to participate in public comment, please press *9 now to take your place in the queue. Chair, you have no callers wishing to participate at this time.
Thank you. And with that, we will close public comment. Thank you. Thank you to the committee members for your patience and your pointed questions. And with that, the meeting is adjourned.